My today's topic is CKD early diagnosis, screening and prevention at primary care level. So is that CKD screening and early diagnosis important in our country? Yes, because CKD is a burden to our country. In Anuradhapura district, only there was 10,677 patients were diagnosed with CKD and nearly 4,000 patients died with CKD since 2019 up to 2021. We do not have recent statistics. At the point prevalence was much high in Anuradhapura district compared to Polonnaruwa, and nearly 2,000 patients per year newly diagnosed with CKD. However, the morbidity rate was slightly lower since 2019 because we were able to expand the dialysis program, CAPD, as well as recently we are establishing the transplants as well. So for the year, there are 13 dialysis machines with 110 patients getting dialysis treatment. Kapdigol level 4 newly started satellite unit, and Madhavachia, we are going to expand it to 10 dialysis machines, and Thavutegama with 5. And this is some pictures of it. So is that WHO screening principles apply for CKD? Yes, of course. Why is that? Because early stage CKD is completely asymptomatic. Until CKD stage 5, patients are asymptomatic. They are not developing any symptoms. So that's why CKD screening is very important. And it's detectable by affordable testings, and treatments are effective and available, and disease progression is very well understood, and screening treatment must be ongoing, not just a one episode. So that is the conceptual framework of CKD screening. We have to determine individuals, populations who are level at risk, and then initiate CKD screening. Once the CKD diagnosis is confirmed, we have to risk stratify for staging and prognosis, and then we have to treat in the early stage. So I will give you a few examples why screening is important. This is a 22-year-old, just a young female who was diagnosed with type 1 diabetes mellitus for 11 years, presented to us with bilateral exhaling and proturing for 3 months duration. And on admission, her GFR was 22 ml per minute with UACR of 10,330. And yesterday we did a renal biopsy. The unfortunate thing is for 11 years, she didn't undergo a single renal screening until she developed these symptoms, and GFR that time now 22. So this is another example why screening is important. This patient, this young male, he's just 33 years, currently getting dialysis treatment at DGH Vaunia, waiting live transplant at Teaching Hospital Anuradhapura. His younger brother was diagnosed with end-stage renal failure, and he underwent live transplant from his own sister. And his own sister is completely fine. Her screening test was normal, and frequently she underwent screening because she had a donor nephrectomy. However, he was never ever undergone a renal screening test. As previous lecture mentioned, we can have early epigenetics, and changing epigenetics is possible if this is a genetic factor, right? She's family history of CKD, but he presented to us as a crash lander with serum creatinine of more than 1,000. He never underwent a single screening test in his past life. But his sister was fine because she was completely screened. And the other one is the fourth successful cadaveric transplant recipient. His younger brother also diagnosed with end-stage renal failure, and he was a crash lander to our unit. And he was also never screened for renal functions. So the additional consideration, patient education is very important, and economic rationale. The economic rationale is that financial, for the screening program, the stratification and treatment, the cost is much less than the cost for dialysis, transplantation or CAPD program. So 4 major topics: selection of candidates, populations for CKD early detection, the relative diagnostic and predictive characteristics of tests for kidney disease and their potential costs, the evidence-based treatments that reduce the CKD progression and cardiovascular events, the implementation strategies for CKD early detection and treatment, and key factors determining resource allocation and cost effectiveness. So How do we determine the risk population? Everyone with hypertension, diabetes, cardiovascular disease, they are at risk of CKD. And high blood pressure, history of preeclampsia, diabetes, past history of AKIs, family history of kidney disease, that is very, very important. And obese patients, and occupation and environmental exposures, not only for agrochemicals, any hazards, paint, some constructional workers, they are risk. And past history of snake bites, history of leptospirosis, and other medical conditions, including HIV, SLE. So all those group of patients, people are at high risk because we can't do screening for everyone. We have to identify the individuals, people who are at risk, and they need to be early screened and early diagnosed and early treated. So initiation, frequency, and cessation of CKD. There is no hard and fast rule when to initiate screening, what is the frequency, and when to stop screening. So we should identify the high risk group people, and we need to frequently monitor them. So this is a kidney failure risk equation. Anyone can identify it through the Google. When we put age, sex, TFR, and urine protein creatinine ratio, we can get the kidney failure risk assessment that determines whether in 2 years' time or 5 years' time patient might need RRT. So that time we can, once we establish the kidney failure risk, if it's more than 3%, these people are high risk for kidney failure in 2 years' time and need to refer to a nephrologist early. So poor adherence to screening guidelines is one of the major factors for this development of end-stage renal failure. UACR screening in diabetic population in the world is only 42%, and hypertension population in UACR screening is only 6%. That's very low value. So what are the ideal initial screening tests? Serum creatinine, UACR, serum cystatin C. So this is the guide to diagnose CKD and the staging of the CKD. Once initial screening done, we need to stage the CKD, whether it's a normal G1, G2, G3A, G3B, G4, or G5. The red areas are high risk groups and the green areas are no or low risk groups. So as we all know, this UACR, if less than 30 milligrams per gram or less than 3 milligrams per millimoles, that is normal. 30 to 300 milligrams per gram or 3 to 30 milligrams per millimole, that is subnephrotic range proteinuria, and more than 300 milligrams per gram or more than 30 milligrams per millimole is nephrotic range. So with that, this is how with the EGFR, how do we stage the CKD? So the cutoff value beyond CKD, this is CKD stage 3. If it's like 30 to 45, we call it as CKD stage 3A. In between, 45 to 60, we call it as CKD stage 3A, and 3B if it's 30 to 45. So there is low rates of albuminuria testing. Is that, can we replace urine dipstick test for urine albumin creatination? No, because urine dipstick test is having very low sensitivity. So UACR is the ideal method with including the serum creatinine. Is that serum cystatin C measurement important? However, in our country, it's not freely available, but serum cystatin C has the additional advantage of offering EGFR estimates that do not require the incorporation of the race coefficient. Cystatin C is more specific than serum creatinine for cardiovascular disease prediction. So I will show why it is important, because in the red line, that serum cystatin C is having a linear relationship with all-cause mortality and end-stage renal disease progression. But the serum creatinine value is not having a linear relationship because it can vary with the drugs and muscle mass. So serum creatinine is not having a linear relationship, right? But serum cystatin C is having a linear relationship with the EGFR and all-cause mortality. And cystatin C and albuminuria is a better prediction of cardiovascular disease risk than serum creatinine. So how do we screen? How do we risk stratify? So we have to identify the people who are at risk. As I already mentioned, hypertension, diabetes, cardiovascular disease, prior history of AKI, family history, obese patients, and people who are environmental exposures and genetic factors. Then we start screening with UACR and serum creatinine and available serum cystatin C. How do we diagnose is confirm the CKD after only diagnose it if the EGFR less than 60 or USCR more than 30 for more than 3 months, then we define it as chronic kidney disease. Once CKD is confirmed, we have to stage it and then we have to assess the risk factors and modify the risk factors. That is how we risk stratify and then treat them. So lifestyle improvements that definitely may help to reduce the progression of all stages of CKD. This study showed that modifiable lifestyle hazards can predict the incidence of CKD in the community and may inform both public health recommendations and clinical practice. So what are the lifestyle modifications? Smoking cessation, well-balanced diet, fruits, Mediterranean diet, vegetables, legumes, and limiting dietary salt intake. Maintain a healthy weight. Regular exercises, including yoga. Advise patients to avoid herbal medicines, neuropathic supplements, NSAIDs, PPIs, and decongestant. Because we are seeing lots of people with NSAIDs and PPIs who are at high risk of CKD. So this is the pharmacological treatment. Just move on to the pharmacological treatments. SGL2 inhibitors, ESE inhibitors, OARs, statins, and metformin. So this is the renal trial. I think everyone knows about the renal trial. That showed that in diabetic nephropathy patients, they include that losartan treatment group compared to placebo had reduced risk of CKD progression. They mainly include the diabetic nephropathy patients. But the other meta-analysis study showed diabetic and non-diabetic proteinuria patients, ESE inhibitors or ARBs reduce the CKD progression compared to the non-treatment group. But non-proteinuria, it's inconsistent. So this is the other trial, SPRINT trial, which is the largest trial of antihypertensive. That is a randomized controlled open label multi-center controlled trial that showed they include patients with non-diabetic CKD also with age 50 years or greater. That showed intensive treatment group compared to the standard group had reduced occurrence of MIs, acute coronary syndrome, stroke, heart failure, death. So that is important, but they use standardized office blood pressure, not the casual office BP. So what is standardized office blood pressure measurement? That patient should be rest in a quiet room and avoid smoking, caffeine, exercise for more than 30 minutes with empty bladder, and the cuff should be in the bare hand, in mid arm cuff, and calibrated with the validated manual auto blood pressure meter. So if we monitor with this, the target blood pressure should be less than 120 over 80, but that is called standardized office BP measurement. So other studies showed statins. Statins will not reduce CKD progression, but it reduces cardiovascular disease risk, especially beyond CKD stage 3. So this study showed that the statins lowered cardiovascular disease, especially aged more than 50 years. Everyone is having cardiovascular disease risk. Less than 50 other additional risk factors. People with additional other cardiovascular disease risk factors need statins, but they will not reduce the CKD progression. Other thing, glucose control. Intensive treatment is reduce the risk of CKD progression in type 2 diabetes with target HbA1c less than 6.5%. So this is a miracle drug, SGL2 inhibitors. More than a diabetic drug, I would like to call it as a cardiac and a renal drug, because I will give you a few trials about the SGL2 inhibitors. This is a credence trial. That is, they include people with only diabetic nephropathy patients, type 2 diabetes with USCR more than 300 milligrams per gram, with the mean age of 62, with mean EGFR of 57, with mean USCR of 927. that patients who were treated with canagliflozin compared to placebo had reduced the risk of kidney failure and cardiovascular disease events. So, other trial was DAPA-CKD trial. They include both diabetic and non-diabetic, not only diabetic, non-diabetic, both proteinuria patients. And their EGFR was much lower. Like it was like EGFR of more than 25 to 75 ml per minute. All patients were in maximum tolerated ACE inhibitors, and they include both diabetic and non-diabetic proteinuria. The DAPA treatment group compared to placebo had statistically significantly reduced the risk of kidney failure, cardiovascular deaths, and hospitalization for heart failure and all cause. So that is a really important trial because they include both diabetic and non-diabetic proteinuria with GFR of more than 25. And the other trial was IMPA kidney trial. They include slightly lower EGFR up to 20 to 45 ml per minute people, and proteinuria patients, significant proteinuria, USCR more than 200. So, empagliflozin treated group had reduced the CKD progression and cardiovascular disease risk compared to placebo. However, that the risk of ketoacidosis and lower limb amputation was slightly higher with the EMPA treated group. So GLP-1 receptor antagonist is not freely available in our country, but we can use it once the EGFR is lower, because we can't use SGL2 inhibitors if the EGFR is lower, like less than 25. So then we can use these, but that will reduce only the CKD progression, cardiovascular disease risk, not the CKD progression. So this is Fidelio-DKD trial. It's a randomized double-blind trial, including 5,724 patients with CKD and type 2 diabetes with USCR of more than 30 and EGFR of more than 25 to 70. And all patients were treated with RAS blockage. Treatment with finerenone results in lower risk of CKD progression and cardiovascular events than placebo, with a slight risk of hyperkalemia. So this is important. How do we slow the CKD progression? How do we identify the risk? The patient's safety. Once the EGFR less than 60, we need to modify our doses, and we need to reduce the risk of AKIs with adequate hydration. We have to avoid volume depletion, avoid dual blockage, because some practices I saw ACE inhibitors combined with ARBs should not be done. And the other thing, to prevent the contrast-related AKIs, use the lowest possible radio contrast and adequate hydration, withhold ACE inhibitors or ARBs, and diuretics and metformin prior to the contrast. And in between EGFR 45 to 60, we have to avoid NSAIDs, and especially PPIs as well. And beyond 30, below 30, we can't use metformin, but 30 to 45, we can use the half dose of metformin. And below 30, we have to avoid NSAIDs, we have to avoid bisphosphonate. Sometimes bisphosphonates are given in when EGFR even less than 30. We should not give bisphosphonates when EGFR is less than 30. And we have to avoid metformin. So, patient engagement is critically important. Improve access to patient healthcare, improve access to adherence to medication, timely nephrology referral, dietitian referral, proper diabetes education, that is important. And patient-related barriers are lack of knowledge of CKD and their associated risks. That's why we are meeting lots of crash landers of CKD. And social risk factors, malnutrition, and lack of education. And health system-related barriers, lack of knowledge of CKD guidelines, and lack of communication. So we can do measures to define success CKD screening program, success CKD risk stratification and treatment. So as patient-related, like lifestyle modification and education, and then treatments. ACE inhibitors or ARBs, statins, as I mentioned all the things earlier. So we need more trials to design this testing of CKD early identification and intervention programs. Then I would like to highlight a few things about risk factors for CKDU, which is endemic in some areas in our country. So we don't know exactly what are the risk factors, but it is multifactorial. Heat stress is one of the risk factors. Occupational exposure, inhalation and ingestion of dust and toxins, including agrochemicals, can be reduced with safe practice, wearing PPEs, wearing double gloves, masks, like that. And drinking superficial well water contaminated with agrochemical toxins, any toxin is a risk factor, can be reduced with filtered RO water. And genetic, more than might be genetic or beyond genetic factors, because we are coming across autosomal dominant tubular interstitial disease and then malnutrition. So this is some biopsy findings of a CKDU patient. This is tubular interstitial fibrosis, and interstitial fibrosis is tubular atrophy and glomerular sclerosis, and from periglomerular sclerosis as well. Still, we don't know. And the intervention trials are not enough, adequate to treat for the CKDU. There are few trials. There's a single center double-blind randomized controlled trial on steroids for patients with CKDU and acute interstitial nephritis confirmed in renal biopsies showed empirical treatment of steroids is a potential treatment to reduce the CKD, but that trial is not strong enough to prove the treatment benefit. We can try with acute patients who are biopsy showed acute tubular interstitial nephritis try steroids. And treatment of hyperuricemia is still, we couldn't get a significant trial evidence, and we need more interventional studies. I'll tell about one trial that is for using with the ESE inhibitors. It's a double-blind, placebo-controlled randomized trial. This was conducted to investigate the effect of ESE inhibitors on the progression of CKDU. That showed enalapril treatment group is beneficial in reducing albuminuria, but the CKD disease progression reduction is not significant. There is a EGFR decline, reduction in the EGFR decline in enalapril group, but it was not, unfortunately, statistically significant. So we need more strong evidence about treatment of acidosis, trial of steroids, ESE inhibitors might be other newer drugs for treatment of CKDU. So need a protocol to improve the health population, long-term follow-up. We need systemic records and longitudinal studies. Thank you.